Thank Rob and the conference organizers for asking Intel to open this conference. We're sort of excited to be here. I've never been to Edmonton, so this is sort of a treat for me. Also, being a typical American, I'm metrically challenged. I understand the distance pretty well. I have a son who runs, so I get kilometers. But I have a friend back in Portland, Oregon, and I told her I was coming to Edmonton, and she said, "Oh, it could be 0 there." And I was prepared for it to be 32 degrees Fahrenheit colder than it is now. So I was sort of happy it wasn't quite as cold as that. You could say I have a couple different titles here. Things change quickly at Intel. Yeah. No, I have one on.
This is for the...
So the theme is barriers to adoption today, and so what I wanted to sort of walk through is some motivation on why Intel is in healthcare. Some of you may be familiar with some of the things we do. Some of you may actually be surprised that I'm here and that Intel's talking about healthcare. So I'm going to talk a little bit about our motivation. I want to give a real broad swath of the portfolio of what we do in the market. And then I want to focus on sort of the approach that we take to innovation and some of the ways that we try to mitigate barriers for adoption, and maybe give some sort of a call to action as we talk today and how we might think about different vectors of analysis for barriers for adoption. So about 10 or 12 years ago, a good friend and colleague of mine, Eric Dishman, started a small little research project in the Intel corporate labs, and it was looking at sensor networks, which was really sort of big and hot topic at the time in the labs. And he was really, really interested in healthcare, particularly Alzheimer's patients. And we were trying to think, how could we apply sensor networks to Alzheimer's patients? And so one of the things we did a little demographic analysis. We started to take a look at the market to see, you know, geez, even on the research side, if we start this, is there a place for this to go in the business? And 10 years ago, we're in the middle of it now, but 10 years ago, we saw this looming demographic, right? That you know, we had 10% of the world at 60 plus 10 years ago, and we were looking at by 2050, this growing, doubling, right? And so you've got this sort of start of this geometric progression, and of course, it's like I said, it's obvious we're all in it now, but what comes with that are stresses, right? Stresses on economies, certainly stresses on the healthcare industry, given the way that we do healthcare. The other side of this is as we get older, the irony is, right, is that as we get older, because we take care of ourselves better, even though we're here trying to figure out how to take care of ourselves even better, is that we live longer with chronic disease, right? So the things that used to kill us, we now live with for 5, 10, 15, 20 years. And so living with that has an extreme and profound effect on the healthcare industry that takes care of us. The other thing we noticed, and this was actually an observation from one of our founders and guiding lights, Andy Grove. In a 2004 Fortune magazine article, Andy likened the healthcare industry to the technology industry in the era of the mainframe. So what does this mean? Well, if you go back 30 or 40 years and you wanted to do some computing, the way that you did it was you called up your local university, you made an appointment, you got in your car, you drove to the university, you went to a building, you went into a room that was maybe half this size, that was filled with technology. You took your punch cards, you put it in, and you got some printout, and you went home and you looked at that printout. And if you needed to do more computing, it was sort of repeat again, right? And it wasn't until the invention of the PC, which of course Intel was right in the middle of, that people actually got economies of scale, right? And they were able to take those PCs and in their living rooms do the same kind of work that they used to be able to do going to the university to do it, right? So it made it easier and really follow what we call Moore's Law, right? Faster, better, cheaper. The idea that we could cut the price in half and double the compute power every 18 months or 2 years. So how does that relate to the healthcare industry? Well, this picture here, and I need to do a disclaimer, this is the Oregon Health and Sciences University in Portland, and I'm not maligning OHSU because we love OHSU. In fact, I was just there this week for my own healthcare, and we collaborate strongly with them. I'll actually talk about some of the great collaborations we have with them. But it's a really pretty good instance of a big, sprawling institution, right? I mean, this baby's massive up on the hill in Portland. And so how do we do healthcare now, right? Well, we wait till you get sick or your mom gets sick, and then we force them to do their pilgrimage to the healthcare mainframe, right? And then we administer numerous expensive tests on them. We treat specific problems they came, give them a bunch of medication, and we tell them to go home and do what we told them to do, and we repeat as needed, right? And so here's that sort of apt analogy between the mainframe and the technology and the mainframe and the healthcare crisis, right? So you're starting to take a look at this huge demographic coming and sort of then the way we take care of people. Now also, right, and this is maybe a little bit more recent, but I think these have been problems, issues that are brewing. And this is really somewhat US-centric, but even as we've looked across Europe and in other places, even single-payer places, much like Canada, right, we've noticed some of the very, very same issues, right, that docs are paid per visit. I mean, the model is, right, that a doctor sees you when you're sick. He's not paid to keep you healthy. That's sort of weird. I know doctors want to keep you healthy. That I have not, again, not maligning doctors, right? That's what they want to do. But they get paid when you're sick. They don't get paid when you're healthy, right? And that for the most part, they only get paid when they see you face to face, when you go into the doctor's office. There's not a lot of quality metrics, right? And the team that they have is the team in their office. It's hard for them to coordinate across a bunch of different specialties, right? And so we know in the healthcare reform policy in the United States, there's a lot of discussion around capitated models, care coordination, being able to pay a certain fee to take care of somebody that actually incentivizes people to keep people healthy and to keep them from coming back to the doctor's office more regularly. And we actually believe that this is a real ripe area where technology can help with efficiencies and help take care of people. So we actually find this is a very, very positive thing from our standpoint. And lastly, right, we also see that around the world, governments are spending lots of money on healthcare. You know, healthcare information technology generally is about 10 years behind other industries, right? They're catching up, but generally they're behind. We're starting to see adoption of medical records and updates to IT systems, but you know, there's a trend towards extra spending. So you put all this together in terms of what we looked at, the demographic, the models of care, the policy change, the potential change in business model and government spending. And this looked like a really, really interesting place for Intel to get involved, both in that we could help people, but there's also a big business value because we're in business, right? So let me take a second to talk about what we're doing in healthcare. So Intel's really in the process of evolving what we do. And in fact, even the latter part of this presentation, when I talk about our user experience approaches, is a direct instantiation of that. We're really evolving from just a chip company to what we call a computing solutions company, right? Where we're looking more at software, looking more complete solutions, and potentially even services, right? And in fact, healthcare is a poster child for this, right? Because it's really about trying to deliver a solution into the industry versus just little small components. This slide is something we put together probably 6, 7 years ago, and it's really helped drive how we look at a very high level at delivering solutions into the marketplace. We call it shift left. As you can see on the x-axis, there's cost of care, increasing cost of care, and on the y-axis is quality of life. And obviously, right, we all want to be on the top left. We want to be happy, we want to be healthy, and we want to be at home. But as we need to move through the system, we get more tests administered to us, we have more constraints put on what we can do, and we spend more money. And part of what we look at in essence is philosophically applying Moore's law to any one of these. And so what does that mean? That means that can we take services or care that's here and develop technologies to push it to residential or ambulatory care? Can we take the services that are provided at residential or ambulatory care and push them to the home, right? Starting to get those economies of scale that I talked about before. One great example of this, and Intel's not involved in this, but a great example of how technology worked here is in diabetes, right? Because as you know, you can't manage your diabetes by going to see your doctor once every 3 or 4 months and having him check your insulin and your blood sugar. That's not how the disease works, right? This disease requires you know, daily, if not hourly, monitoring. And so technology has been developed, these insulin pumps, right, that where people can wear these all day, you don't see them, right? You don't know they have them on, and it really helps take care of them and helps them take care of themselves. I have two nephews who have diabetes. They're both out of college now, but when they were in high school, they played basketball. And they had these pumps on, and they played as aggressively as anybody else, and you did not know they had them on. I mean, it was absolutely amazing, right, that these teenage kids could take care of themselves and live normal and happy lives. And this is the kind, you know, this is the kind of model, I think, that we're talking about here with Shift Left on all fronts. So we've been involved probably seriously in healthcare for 10 to 12 years. We started with some ethnographic research, and I'm going to talk a little bit about the ethnographers and our innovation model in a little bit. And then the project I was talking about earlier that Eric started, we called Proactive Health. And Eric went off and started CAST, which is a Center for Avenue Services Technologies. If you're not familiar, that's a U.S.-centered group out of Washington, D.C. that in collaboration with the American Association of Homes and Services for the Aging. It's a collaboration between assisted living facility CEOs, academia, and industry, and it's really looking at affecting policy and funding for technologies for the home. We started the digital health group at the very, very end of 2004, which was a top-level business unit. Through that, I'll talk a little bit about the products, but we also started an industry consortium that's now worldwide called Continua, and that's looking at interoperability standards for medical devices in the home. We've been involved in HL7. We came out in 2007 with the first purpose-built tablet for nurses and clinicians. And then we've got some software products, and we came out with the Intel Health Guide in 2008. Around in the middle of 2009, so the story goes, I wasn't on the call, but the CEO, Jeff Immelt of GE, called our CEO, Paul Ottolini, and said, hey, I really like what you guys are doing, let's talk. And so we were quite excited about that. GE's a really, really trusted name in healthcare. We were trying to get our feet in the water there. And to make a long story short, after a bunch of negotiations earlier this year on January 3rd, GE Home Care and the Digital Health Group at Intel merged to form a joint venture called Care Innovations. Care Innovations started with two products that Intel had put together, the Intel Health Guide, which is a remote patient monitoring system, and the Intel Reader, which is a standalone system that is assistive technology for those with macular degeneration and dyslexia. And GE had Quiet Care, which is a really, really interesting SensorNet solution. One of the very first that was on the market. And in fact, when I talked about we were doing SensorNet research back 10 years ago, we watched these guys. It was sort of interesting they ended up in our laps because we watched these guys because they were the only guys on the market at the time, right? And so now they've got this portfolio of products. They're doing well. For their first year of breaking away from their big and hairy parents. You know, one of the main motivations for them breaking away was business model flexibility, right? And we'll talk more about that, I think, throughout the day. But the fact that you know, GE and Intel at the core of it have certain business models on how they do their core business. And these guys really needed more flexibility, and it was hard for them to do that at the parent companies. And so I know when we started talking to the GE folks, there was a kindred spirit in frustration of simple things they couldn't do and things that they wanted to do that were hard. And it was very, very forward thinking of the two parents to let their child go off and seek his fame and fortune. So we're excited about Care Innovations. Back at Intel, we have a broad portfolio of stuff we continue to do in healthcare. We sell into the embedded market in imaging, diagnostics, and therapeutics. We sell core product into hospitals and payers and doctors' offices. We have software and solutions, and that continues to grow for us. We have an integration product that started in the Digital Health Group that remains at Intel, as well as sort of cloud computing solutions for a variety of different things. And then, of course, we have the research and innovation that continues, whether it's looking specifically at gait and falls or mobility. There's a lot of different research vectors. So we have a whole portfolio of things we do at Intel as well. Okay, so I want to talk now a little bit about sort of what the core of what I think Rob asked me to talk about is how we sort of do innovation at Intel. And one of the things that motivates how we do it, right, is this idea of mitigating barriers to adoption. The team that I have been working with, and we don't just do this in healthcare, we do this across all of our businesses, and it's been growing over time, is we put together interdisciplinary teams of ethnographers or social scientists, designers, and engineers to do innovation on the front side, right? And we sort of affectionately call this the 3 E's, right? Ethnography, evidence-based, and ecosystem development. The ethnographers will do field studies, and I'll talk a little bit more about their output and how they do their work. But then they come back in and they collaborate with the designers and technologists, and we actually put together solutions that we go back out and test, whether it's testing product features or doing, you know, primary research and looking further out. And then something Intel does really well in every place is ecosystem development. I'll talk a little bit about standards, collaboration with research organizations, sort of floating all boats, so to speak, in the marketplace. So we start by the ethnographers going out into the field, and some of this output is from a very broad study we did across the world called Global Aging. But what ethnographers do, right, is they go out and they shadow, and they sometimes live with people where they work and where they play. And they don't do big studies of thousands and thousands of people. They do like tens, and they go very deep. They look for detail, right? They look for tiny detail of what people do. They try to observe things that people do that people aren't even aware of. And when they come back after their studies, they have field notes, they have videos, they have photos, and they have tons of stories. Ethnographers are great storytellers. You ever get a chance to go hear one speak, you'll like it, because they know how to tell a story, right? But a story doesn't, in and of itself, get you to product requirements, right? So there's a whole bunch of stuff we need to do. But they come back, we put together what we call opportunity maps, high-level areas that we look for intersections across the people that we study. Sometimes they'll come back with concept designs, segmentation on a variety this isn't really a customer segmentation so much as just a segmentation that they saw across a bunch of elders and how they deal with their health in the healthcare system. And then we bring them back, and we have what's called harvesting sessions. And these harvesting sessions is where we bring the designers and the technologists in. And the designers that we have are also sort of interdisciplinary. We have industrial designers, and these are people who understand form factors, physical objects, and how we interact with them. We have software designers that understand how you interact with the computer interfaces. We have human factors engineers who understand how the whole system works. And then, of course, what we're known for is all the geeky technologists, right? And when we come back, then they start to take a look at what are those intersections of those needs that they're finding and the potential application of technology and the technology that we might be able to apply, and where are the best places for those intersections. I just want to take a minute to notice these drawings here are actually from early harvesting and design sessions from the Intel Health Guide form factor. So you saw that the big clamshell on the Intel Health Guide, and these were original drawings on what that might look like. So once we do that, and we sort of have an idea of, well, we have some technology that we might actually want to test, we'll come up with research projects, and we'll go back out in the field, and we'll test them again. And there's a whole continuum here. I'm going to talk more on the research side, but there's a whole continuum here that we do everything from sort of adding product features to existing products, all the way to primary research, where we're looking for correlations that we that don't exist yet. We've done everything here from medication trials, looking at if we can get people to adhere to their medication through different kinds of prompting techniques. Up here, you can see the woman who's blurred is walking, and there's sort of a rail right at her neck level. That's actually what we call the velocity rail, and what we were looking at there is, can we correlate changes in gait speed with the likelihood of someone's to fall. We spend a bunch of time on the sensor, on the body sensor and SensorNet side, and we actually came up with This is called Shimmer. It's a small on-the-body sensor, reusable, that we started building ourselves so we didn't have to rebuild a sensor every time we did a project, and we ended up getting a lot of interest from the research community, and we actually ended up licensing that out to a small company in Ireland who now has a subsidiary in Cambridge, Massachusetts called Shimmer, who sells those. So a variety of different things. I want to take a digression for a couple slides and actually show you a couple projects that we've done in this space, because they're just so cool that I have to share them, because I love presenting these. They're so much fun. So the first one was the medication prompting. And so I just want you to look at the top of the slide. Do I have a pointer here? Oh, cool. At the top slide. So this is a 24-hour. This is one day in the life of this woman who lives in an apartment. And what we did is we outfitted her apartment with a bunch of different sensors. We have a phone sensor. We weren't taping. We were just telling if they were on the phone, so we didn't break any laws. And then we had motion sensors in the rooms to see if there was activity. The iMed door is that it was the medication device that we talked about. And the front door and the fridge were just switches to tell if the front door and the fridge had been opened as a proxy for a day. So here, about 2:50 in the morning, the front door opens, and it's like, oh, okay, well, that's a little strange. Why is the door open at 2:50 in the morning? There's a bunch of activity. The house doesn't go too quiet for that long, and she opens the front door again about 4:45. We know this is not a normal pattern for this woman, because we talk and we interviewed her. But we also know, though, that so on the research side, all this data is going back to researchers, but you can imagine a commercial product that was going back to a call center, somebody's watching this stuff, or a clinician. If in fact, the door had opened and the house had gone quiet for any length of time, that could have been something that was of concern that we needed to look at. But in this case, it wasn't. At 6 a.m., she gets up and opens the door. Now, this is normal pattern. She gets her paper and she goes back in her bedroom and she reads for a while. She gets up at 9 o'clock, the fridge opens, oh, she's on the phone, she's talking to people, she's moving around, so that's good. She's social, she's active. Around 2:15, the door opens, the house goes dead, that's good too. She's out in the afternoon, she's meeting people, right? She comes back around 5:30, lots of refrigerator activity, more on the phone, lots of activity, so good social patterns there. And then she goes back to bed around 11:30. So it's really sort of cool that you can get a sense of what this woman's doing just by sensor firings. Now, does this have something to say about her health? Well, 1 days of data, maybe not, right? But if you can start to put these together, days, months, weeks, years, and start to look for patterns of normalcy, or even more important, patterns of abnormalcy, right? There may be things that we start to see that we haven't seen before. And in fact, this is a study that OHSU did, Orcatech, the Oregon Center for Aging Technology, and this is actually about 9 months worth of data. So let me explain. Oh, back, sorry. Let me explain here. So this, again, is a 24-hour clock, right, from midnight to midnight. Each concentric circle is about 2 weeks worth of data. And each dot is a sensor firing, and each color is a different place in the home where the sensor was fired. So pretty simple. This woman here lived in a house or an apartment, I believe, and this woman here lived in an assisted living facility. So what can we tell by looking at the spiral plot? Well, the first few months, her sleep patterns are pretty good, and then things change pretty rapidly. She's up a lot at night. Again, is this indicative of a problem? We don't know, but maybe something worth talking to her about, right? The other thing we want to notice is that there's these dark sort of patterns here in the house, and in fact, they correlate to meal times, which is good, right? So there's a lot of activity in the kitchen around meal times. Similarly, over here at the assisted living facility, we take a look at this woman's sleeping patterns, and they're sort of not really good from the very beginning. That may be normal for her, or may indicative of a problem she has. Again, we don't know. Lots of activity in the morning, and then, you know, these quiet spots in the house that are really quite marked. And in fact, this is when she goes down to the cafeteria to have her meals in the assisted living facility, right? So again, we start to see patterns that are really hard to see otherwise. OHSU also did a separate study where they were looking at folks with cognitive decline and actually were able to show some correlation with decreased activity over time and a decrease in cognitive decline. So it's those kinds of things that are exciting, we think, that can come out of this kind of research. The last E is ecosystem. I talked a little bit about some of these before, right? Getting out there, starting collaborations out. I talked about Orcatech and our work there, and CAST and HL7, Continua. Trill is a big collaboration we've had with the Irish government on doing a whole bunch of research there in Ireland. Our latest effort is called Silver, which is the Senior Independent Living Research Network Initiative. And it's just at the very cusp of starting. We're not sure how far it's going to go. But when I showed you the SensorNet stuff we did in Oregon, we do that in what we call a living lab out in the Portland area. We have almost 200 homes that are outfitted that we can get in and out of at any time and gather data from. And as we're starting to look for correlations, we really want to be able to grow this. In fact, the vision is to grow this to 10,000 households. And the Silver Network, we've had one workshop with the National Institute of Health in the United States and Robert Wood Johnson and a few other big interested parties. And we're really looking to see, can we get some funding and get some infrastructure in place to grow a living lab around the world that goes from hundreds to thousands or tens of thousands, where we can test technology in the homes and really get statistical significance on a variety of different points. So that's one thing there. So what I'm really talking about then is a process, right, from how we get from the front end to product development, right? I talked about studying people and their practices, prototypes, proof points and pilots, getting to platforms and products. And the other thing that we overlay on top of this through the very, very beginning, even on the research side, is sort of this cross-functional iterative analysis on 3 vectors: business, technology, and usage. Now this seems sort of self-evident, and it's sort of like, yeah, that makes sense. But if you think about how your organizations are set up, I would argue, and I bet most of you have all of these different functions siloed in some different place in your organization, and they all have their own turf, and they all own certain pieces, and getting these guys to work together is really, really hard, right? And in fact, I've done this. Part of my job was to try to make this happen. And it's surprising when people say, you know, well, yeah, I'm on the innovation side, I do incubation, and my job's about relationships, right? Because my job's about getting a bunch of people to work together who normally don't work together. And when you finally get them in a room and they do the analysis together and you get all these different world views, you start to get a different kind of filter, right? And a different kind of view of what you're trying to do out in the world into potential products. On the business side, you know, just to run through these quickly, right, this is the obvious stuff: finance, NPVs, all different kinds of market segmentation and sizing. But it also has to do with understanding if the business model that you're going after is something that your company is comfortable with. I talked about this with Care Innovations, right, and we struggled with this at Intel, that we had something we wanted to get into that was really exciting, but it was really hard given the business model of Intel, right? And so you have to sort of be aware of that, and what are your options for getting around those issues. Similarly, on the usage side, most people think about, you know, user experience and usage as direct to consumer, you know, or developing an iPod, which is, it's true. But we also need to look at, particularly in the healthcare industry, you know, what are the workflow changes that happen to the healthcare workers? What is the workflow changes to the primary doc, right? How are we going to change their business by integrating technology? And this is a huge barrier to adoption. I know I'm sort of preaching to the choir here, right? But these are very, very important things, and sort of using that ethnographic, user-centered approach to go in and study those has been really, really fruitful for us. And finally, the technology, same thing, right? Are you building technology that's in your core competency, or if it's not, or technology is not your core competency, right? How do you get it to ensure that the right things are delivered, that you can manufacture them, and that they're within your cost range? And so, really looking to find that sweet spot in the middle, right? And doing the analysis that shows that all 3 of these vectors are going to work for you is important. Now, before I close, I want to give a couple examples of this. The first is Apple. And they're the canonical example sort of almost everything right now. But with sort of the sad and untimely passing of Steve Jobs, there's been a ton in the media about his innovation, Apple's innovation, his impact on the world. And what I've observed is there's been a tremendous focus on these two vectors when you talk about Steve Jobs, right? You talk about how cool an iPhone is, how cool an iPod is, all the things you can do with it, the technology, the user experience. I've heard a lot of the media folks say that, you know, Steve Jobs changed how we listen to music. And all that's true. But I would argue what they don't talk about is even more important, equally as important if not more, and that's it. Steve Jobs changed how we buy music, right? I mean, he changed how we store music. And it didn't dawn on me until I converted and put my 100 CDs onto iTunes, and now I buy off iTunes. I realized, you know, my iPhone's going to come and go, and my iPad's going to come and go, and my iPods are going to come and go. But you know what doesn't come and go? My iTunes. It's there forever, right? It's like, I'm tied. That's brilliant. That's brilliant, right? And it also makes sense because it's easy. And so I think it's that business innovation, right, that was behind this that really makes Apple the powerhouse that it is. And so if we get back to healthcare, I think about all the mHealth hype that's going on. I know I think it's huge worldwide. It's certainly huge in the United States. And the mHealth hype is all about showing, you know, healthcare applications on your cell phone, and that's very cool. And it is cool. But the fact is, we will not have adoption unless we figure out business models. We will not have adoption unless we figure out how to integrate with data that the healthcare industry cares about, right? It's one thing to have a direct-to-consumer app that's going to help you with your personal health and wellness. Yeah, that's fine. But if you want the healthcare professional to use an application, how is it going to help them work? How are they going to charge for it, right? How are they going to get paid for it? These are the kinds of things I think that need more discussion. So with that said, just in summary, some of the ways that we look at mitigating barriers are through our ecosystem collaborations, our user experience innovation, and I guess the challenge for today as we have discussions is, you know, let's ensure we don't go down one vector and forget the others. Right? Let's sort of keep this in mind, and I'm looking forward to hearing the rest of the talks and discussions today. So thank you, and I guess I have some time for questions if you have any.
Yeah, you talked about the, just at the end there, the business model. I could agree with you more about the challenge with the business models and you know, mobile apps and connecting with all the investments we're making in EMRs and EHRs. Yeah. What's your take on how to bridge that? I mean, it doesn't seem to be getting too much closer these days as it could be.
Oh, that's a really good question. Let me answer the question this way. I also would argue that the focus of mHealth on cell phones is also wrong, right? I mean, we're struggling with getting remote patient monitoring solutions in place. That's mHealth, right? Taking a computer and using that to manage your chronic disease in your home is mHealth, right? It's mobile health. And I think, and we're starting to figure that out, right? But that has all the same problems. The technology is not even the problem. The technology works. We know how to get video into your home and do all that. The problem is, you know, who's on the other end and who pays for it and how do you integrate? But we're starting to see that. I think if you see that kind of adoption and those problems are solved, I think it'll start to move towards, you know, towards the cell phone. But you're going to have to start to see systems to get integrated at a different level. Yes, in the back?
One of the challenges that the people who are at the front end, in front of patients, they have enough things to struggle with, leading a daily requirement. For them to learn new technologies and making a change in the system will be impossible. So obviously, in Canada, government policymaker becomes a very important key player for making any changes in the healthcare system. In the U.S., I guess the payer would decide what would be the most effective way to deal with the healthcare delivery. I was looking at the WHO's newly released mHealth and a number of other documents and OECD's document, and it seems it's inevitable that healthcare has to become global nature, not just a silo in the
Well, I'm not so sure I agree with the common denominator is the cell phone. I think the common denominator is the internet, right? I mean, if you look at the evolution of retail business, right, that used to be siloed and then within a company, and now we do that broadly because of the internet. Now, I know healthcare has different kinds of privacy issues with it, but it still comes back to the business models. So I mean, I agree with you, we should be global. We've got to start local. I mean, look, you guys know it's hard even in the provinces. I know in the United States, probably the most central place that is really forward-thinking on using technology is the VA, right? No surprise. They're a single payer. They have control over everything, right? And so it's easier for them to do that. But we're starting to see, you know, smaller, early adopters start to play with the technology, and I think that will grow over time. You know, the industry, it has to look towards other industries that have done integration, right, and that have done this successfully, because it's been done. Again, I don't think it's necessarily a technology issue. I would argue the security is good enough already, that's not the problem, right? The problem is the way that people get paid and the change in workflow, right? Because you're right, I'm sympathetic, right, that people, and so how do you get two systems up and enough people to see if it works and to make that change? It's just going to take time. I don't have an easy answer. I wish I did. Yes?
I agree with you that how people are paid is one of the barriers, but one of the other big barriers is liability insurance, malpractice. How do you see that changing, or how do we change that barrier to allow the integration and sharing of information? I mean, George, I think it was Bush that talked about capping physicians' insurance might be one of the solutions. Were there some other solutions maybe to address this?
I'm not the best person to speak to that, although I will acknowledge, right, I mean, one of the problems I know the doctors have is, boy, you start sending me more data, now I'm obligated to act on it, right, because if something happens and I miss it, I'm in trouble. Of course, a lot of the technology, though, it does help with that, right? It's not foolproof, but you can actually sort of work by exception and make sure that those things that are only floating to the top that are an issue. But I agree at the high level that policy is going to have to be a huge piece of that. You see it in the United States, right? The fact that the capitated models, exploration with technology, the acknowledgement that technology may be able to help with some of this. But again, no great answer from me on that. Yes, sir.
When we look at the way community-based technologies are used, we can conceive of the fact that we see multiple payers. We have maybe the healthcare system providing some of the support for some of the technologies that are being used, but then the private individual may pay for part of it, maybe voluntary organizations will be paying part of it. And when we look at the way healthcare is provided to seniors in the community, about 80% of the care they receive is through informal carers, not through the formal system. So my question is, in your living laboratory, have you looked at how you could roll out those kinds of complex reimbursement systems so that you could encompass those different payers and still have a single reporting back system to flag an event or an adverse situation?
Yeah, that's a great question, and if you take a look at some of the, I'll use Care Innovations because it's closest to me. I don't want to be here marketing for them, but I will. No, but they have a portfolio approach in their technology. They have the Health Guide, which is in the U.S. an FDA regulated device, right? So there's really tight constraints around how that can be used. But then they've also got GE Quiet Care, which is not necessarily clinical care, and they've got some other products, right? And I think you're exactly right. There's been a lot of discussion, I know, about what would it mean if we could put all these together in a modular fashion, because you're right, the social aspects as well as the medical aspects, right, are equally as important. And in fact, we found that even in our ethnographic research studies, right, that the family and the patient and the healthcare provider are the triumvirate for care. Again, I think it's early, but you're going to start to see solutions like that start to come together, particularly as there's more of us that are going to need them, right? So I think you're exactly right. It's just early. It's just early. Yes?
The last comment with the triangle that come together, it struck me not too long ago that there are a significant number of us that will be utterly alone, who will have family members, close friends. Can you tell us how to support this relatively
Well, you know, again, we definitely have focused on this triumvirate versus one who's isolated. But these technologies that allow, you know, people to video conference and for you to send data and for you to get, you know, news about things that are going on in your community. I mean, these things are going to be there, right? And I think they're going to help somebody who has that family support, and equally as well as someone who doesn't. In fact, even in Ireland, when we did a bunch of studies, you know, the rural folks are quite isolated. And they were really, really excited. We had this project, what we call Building Bridges, where we actually had they could use their telephone to call in to sort of these virtual chats and virtual sessions with people. And in fact, in the United States, there's an organization called Senior Centers Without Walls. And they literally have like 70 one-hour programs a week where people just call in video conferencing. They go on vacations together. They have talent shows. I mean, it's quite amazing and creative what they do. And it's all for people who are homebound and isolated. And so again, I think you're starting to see some people think about these in small, small pockets. But it's absolutely an interesting application of the technology.
Follow-up comment on what mistakes people generally make when they're trying to use technology with the seekers?
Underestimating them, right? I mean, they're one of the fastest growing segments on Facebook, one of the fastest growing. I mean, sure, I mean, look, if you have somebody who's severely cognitively impaired, you know, they're not going to be able to use a computer, but sort of, and also the other thing the ethnographers yell at us about, right, is one senior, you can't lump them together. They are as different as we are, right? So you have to understand those differences. One more quick one.
Maybe within the context of implementation of technology-supported healthcare, we really haven't addressed openly about the disaster recovery. As you know, Japan was really hit by a number of disasters, and population data gets lost radically. And I'm not sure industries are really focusing on promoting their services to healthcare sectors to make sure, not locally, but globally, they can distribute the data storage.
Thank you very much.